All right, welcome to another deep dive.
Yeah.
Today we're going to be talking about the GI system,
A gut.
the gut.
Yeah.
So, as always, we got a ton of really interesting information to go through.
It's quite the journey, this one.
It really is, and like I always say, it's amazing how much goes on in the body that we're just not even aware of.
You take it for granted.
Totally take it for granted.
Until it goes wrong, right?
Exactly, exactly. So our mission is to break down this complex topic into, bite-sized pieces, hopefully help you understand it better.
Pun intended.
Pun intended, yeah.
All right, so let's start with the basics. The GI system, or the gastrointestinal tract, is essentially a long, continuous tube that runs from your mouth all the way to,
The other end.
the other end, exactly.
So we can think of it as having two main parts, the upper GI tract and the lower GI tract.
And of course, we can't forget those crucial accessory organs that play a vital role in digestion.
Yeah, we'll get to those in a bit.
Sounds good.
So let's imagine you're about to enjoy a delicious meal. It all starts in the mouth, where you chew your food, breaking it down into smaller pieces. That's what we call mastication, right?
Right, and your salivary glands also get in on the action, releasing saliva, which contains an enzyme called salivary amylase. That starts breaking down starches right there in your mouth.
Wow, so digestion actually starts before you even swallow.
It sure does.
That's fascinating.
Now, once you've chewed your food and it's mixed with saliva, it becomes what we call a bolus.
Okay, a bolus.
It travels down the esophagus, which is basically a muscular tube connecting your mouth to your stomach.
And there's a little gatekeeper at the top of the esophagus, right?
You're thinking of the upper esophageal sphincter?
That's the one.
It makes sure that air doesn't go down into your stomach when you breathe.
That makes sense. We don't want air in our stomachs.
No, not ideal. The esophagus also has to pass through an opening in your diaphragm to reach the stomach.
The diaphragm being that large muscle that helps you breathe.
The very same.
Okay.
That opening is called the hiatus.
Got it.
And to move that bolus down towards the stomach, the muscles in your esophagus use these wave-like contractions called peristalsis. It's like a synchronized squeezing motion that propels the food along.
So it's not just gravity doing all the work.
Nope, peristalsis is key. And then that bolus reaches its destination, the stomach.
Ah, the stomach.
Yeah.
Kind of like a temporary holding tank for food.
Yeah, you could think of it that way. The stomach churns and mixes the food with gastric juices, which are super acidic and contain enzymes that further break down the food. This process turns the bolus into a semi-liquid mixture we call chyme.
Chyme, okay. And the stomach has its own set of gatekeepers too, right?
Absolutely. At the top, there's the cardiac sphincter, also known as the lower esophageal sphincter, or LES.
Lots of names for this one.
It prevents stomach acid from backing up into the esophagus, which can cause that burning sensation we know as heartburn.
Heartburn, ugh, definitely want to avoid that.
And then at the bottom of the stomach, there's the pyloric sphincter, which controls the flow of chyme into the small intestine.
So it's like a carefully orchestrated system, making sure everything moves in the right direction at the right time.
Precisely.
So from the stomach, where does the chyme go next?
Onward to the small intestine.
This is where the magic of nutrient absorption really happens.
That's right. The small intestine is a long, winding tube where the majority of digestion and absorption takes place. It's divided into three parts: the duodenum, the jejunum, and the ileum. And this is where those accessory organs we mentioned earlier come into play.
The liver, gallbladder, and pancreas.
Exactly. The liver produces bile, which is stored in the gallbladder.
Bile being important for breaking down fats.
Right. And when you eat, especially a meal with fats, your gallbladder contracts and releases bile into the duodenum, the first part of the small intestine.
So it's like a well-timed delivery system.
Very much so. And the pancreas, wow, it's an amazing organ. It has two main functions: endocrine and exocrine. The endocrine function deals with hormones like insulin and glucagon, which regulate blood sugar.
Right, I remember that from our deep dive on diabetes.
Exactly. But for digestion, it's the pancreas's exocrine function that's key. It produces powerful digestive enzymes like lipase for fats, amylase for carbs, and protease for proteins.
So bile from the gallbladder and enzymes from the pancreas all meet up in the duodenum to work their digestive magic on that time.
It's a remarkable collaboration. Now, most nutrient absorption happens in the jejunum, the middle part of the small intestine, and the ileum, the last part, is responsible for absorbing vitamin B12, which is crucial for healthy blood cells and nerve function.
Okay, so we've got digestion and absorption happening in the small intestine. What about everything that's left over?
That moves into the large intestine, also known as the colon.
The colon, where things get a bit, well, less glamorous.
Perhaps. But the colon's job is crucial. It absorbs water and electrolytes from the remaining waste, forming stool.
It also absorbs some bile acids, which are recycled back to the liver.
Right. The colon starts with the cecum, that little pouch-like structure where the appendix is attached.
The appendix, which sometimes causes trouble and needs to be removed.
Unfortunately, yes. But moving on, from the cecum, we have the ascending colon, the transverse colon, the descending colon, and finally, the sigmoid colon.
Quite a winding path.
It is. And that sigmoid colon leads to the rectum, where stool is stored until it's time for elimination through the anal canal.
So we've covered the main parts of the GI tract. Now let's go back to those accessory organs you mentioned earlier.
Yeah.
We've talked about the gallbladder and pancreas, but what about the liver? What makes it so important?
Oh, the liver, it's like the body's multitasking superhero.
Yeah, he does a lot.
It really does. It's the largest internal organ, and it's located in the upper right abdomen, tucked under the ribs. It produces bile, which is essential for fat digestion.
Right, we talked about that.
But it also processes of vitamins, proteins, fats, carbohydrates. It stores energy as glycogen. It helps your blood clot. It even helps your body get rid of toxins and metabolizes medications.
Wow, that's quite the resume.
And it doesn't stop there. The liver also plays a role in your immune system. Oh yeah, it's involved in fighting off infections and filtering out harmful substances from your blood.
The liver is truly a vital organ. We should all be very grateful for our livers.
Absolutely. And one more important anatomical structure to mention is the peritoneum. It's the membrane that lines the abdominal cavity and surrounds all those organs we've been talking about.
It's not an organ itself, but it plays a supporting role.
Exactly. It helps keep everything in place and reduces friction between the organs.
Like a protective lining.
Precisely.
All right, so now we have a good understanding of the layout and how it all works. But how do doctors figure out what's going wrong when someone's having digestive issues?
Well, the first step is almost always a detailed patient history.
The doctor essentially plays detective, trying to piece together clues from the patient's story.
Exactly. They want to get a clear picture of the patient's current situation and any relevant past medical history. This includes their main complaint, of course, but also things like their nutritional and metabolic patterns.
What they're eating, how much, any recent changes in appetite.
Exactly. They'll also ask about their elimination patterns, any discomfort they experience related to eating, any unexplained weight changes, and their bowel habits.
Things like the consistency of their stool, whether there's any blood, how often they go.
Right. And during this part of the assessment, the doctor will focus on any specific GI-related symptoms the patient is experiencing. This could include abdominal pain, indigestion, nausea, vomiting, constipation, diarrhea, incontinence, and any other concerns the patient might have.
So it's like a targeted interview, really honing in on the digestive system.
It is. And then comes the physical examination.
Where the doctor actually gets hands-on.
That's right. It starts with a visual inspection of the abdomen. They'll check for any swelling or distension, any unusual skin markings like stretch marks, the overall shape and symmetry of the abdomen. They'll also note if there are any ostomies, which are surgically created openings.
And they'll take the patient's weight and assess if it's within a healthy range.
Absolutely. And they'll be on the lookout for specific visual clues. For instance, spider angiomas or distended veins around the belly button can sometimes be a sign of liver problems.
Just even subtle details can offer important insights.
They can. And one of the most important things the doctor will ask during the physical exam is this normal for you?
Because what might be normal for one person could be a significant change for another.
Exactly.
Okay, so they've looked at the abdomen. What's next?
Next comes auscultation, which is a fancy word for listening.
Listening with a stethoscope.
Precisely. The doctor will listen to the abdomen in all four quadrants.
To hear what exactly?
Bowel sounds.
Those gurgling noises our stomachs and intestines make?
Those are the ones. Those sounds, which we call peristalsis, are caused by the movement of food and fluids through the intestines. And the characteristics of these sounds can actually tell us a lot.
For example?
Well, if the bowel sounds are very frequent and loud, we call that hyperactive bowel sounds. That could indicate a few things, like a bowel obstruction, gastroenteritis, which is essentially a stomach bug, or even the intestines starting to work again after a period of slowing down, like after surgery.
So hyperactive sounds can actually be a good sign in some cases.
They can. On the other hand, infrequent or absent bowel sounds, which we call hypoactive or absent bowel sounds, can be a sign of trouble. They might be present after abdominal surgery, but they can also indicate more serious conditions like peritonitis, which is inflammation of the lining of the abdominal cavity, or a paralytic ileus, where the intestines basically stop moving.
It sounds like listening to bowel sounds is a simple but really important part of the exam.
It is. It can give the doctor valuable information about how the intestines are functioning.
Okay, so we've got visual inspection, we've got listening to bowel sounds. What else is involved in the physical exam?
Well, while we're on the topic of what comes out of the GI tract, observing stool is also a really important part of the assessment.
Stool, as in,
Poop, yes.
not the most glamorous topic, but definitely important.
Absolutely. Doctors will assess the color, consistency, and any unusual characteristics of the stool. There's actually a tool called the Bristol Stool Chart.
A chart for poop.
It might sound funny, but it's actually very helpful. It's a visual guide that helps patients describe the consistency of their bowel movements. Different types of stool on the chart can correlate with things like dehydration, lack of fiber, or even conditions like irritable bowel syndrome.
So the shape and texture of your poop can actually tell us something about your health.
It can. And doctors will also be on the lookout for specific abnormal characteristics. For instance, stearia, which is greasy, pale, and foul-smelling stool, often indicates a problem with fat absorption.
And Melina, those dark, black, tarry stools usually means there's bleeding somewhere higher up in the GI tract.
That's right. And then there's the Guaiac test, which is used to detect hidden blood in the stool. This can be a sign of various GI issues, from ulcers to polyps to even cancer.
So paying attention to your bowel movements and reporting any changes to your doctor is really important.
It can't be overstated. Early detection is key for so many GI conditions.
Absolutely. And the material you shared also provided some definitions for other terms related to GI symptoms. One was ascites, which is the buildup of fluid in the abdominal cavity.
It can cause the belly to swell.
And dry heaves, those unproductive attempts to vomit when nothing comes up.
Ugh, those are the worst.
Then there's tenesmus, which is that feeling of constantly needing to have a bowel movement even when your bowels are empty.
And impaction, which is when hardened stool gets stuck in the rectum.
And who hasn't experienced borborygmy, those loud rumbling or gurgling sounds our stomachs make?
Especially when we're hungry.
Okay, back to the physical exam. What comes after auscultation?
Palpation.
Which is?
Touching.
So the doctor will actually press on the abdomen.
Exactly. They'll use their hands to feel for any unusual masses, tenderness, or pain. They'll also assess for distension and firmness.
And again, they'll ask that crucial question, is this normal for you?
Absolutely. Because what might feel firm to one person might be completely normal for another. And just to reiterate, the four main components of a thorough GI assessment are inspection, auscultation, percussion, which involves tapping on the abdomen to assess underlying structures, and palpation.
So they're gathering information through sight, sound, and touch.
Precisely. It's a multisensory approach to understanding what's going on inside the abdomen.
Okay, so we've covered how doctors gather information through the patient's history and a physical exam. Now let's dive into the world of diagnostic tests. This is where things get really interesting, right?
It is. This is where we can really start to see what's happening inside the GI tract. Broadly, we can divide these tests into two categories: radiographic studies, which use some form of radiation, and non-radiographic studies.
Let's start with radiographic studies. One that I'm sure many people have heard of is the upper GI test, also known as a barium swallow or upper gastrointestinal series. What exactly does this test involve?
Well, it involves drinking a liquid that contains barium, which is a contrast agent that shows up really well on X-rays. Then, using fluoroscopy, which is kind of like a live-action X-ray video, the doctor can watch how the barium travels through your esophagus, stomach, and the first part of your small intestine, the duodenum.
So it's like a real-time movie of your upper GI tract.
Exactly. And this can help detect a whole range of issues like ulcers, hiatal hernias, tumors, any abnormalities in the shape or position of these organs, inflammation, problems with swallowing, and even aspiration, which is when food or liquid accidentally goes down the airway instead of the esophagus.
So it's a very versatile test.
It is. Now, the barium itself, or sometimes a similar contrast agent called HIPEC, has a bit of a chalky texture and taste, even though they try to make it more palatable with flavorings.
I've heard it described as tasting like, well, chalk.
Yeah, that's a pretty accurate description. And you usually have to drink quite a bit of it, about 12 to 14 ounces, while the doctor watches it move through your system using the fluoroscope.
So it's not the most pleasant experience, but it can provide valuable information.
Absolutely. And it's important to note that there are some specific preparations you need to follow before this test. For a couple of days leading up to it, you'll likely be on a low-residue diet, which means avoiding high-fiber foods. You'll also need to be NPO, meaning nothing by mouth, including water, for 8 to 12 hours before the test. Sometimes they'll give you a laxative to clear out your system beforehand.
And smoking is a no-no, right?
Right, you usually have to avoid smoking for 12 to 24 hours before the test because it can stimulate stomach activity.
And what about medications?
Most routine medications are held on the morning of the test, but it's always best to confirm with your doctor.
So communication is key.
Always. Now, here's a really important point. After any test that uses barium, it's crucial to drink plenty of fluids. Why? Because barium can be constipating.
Ah, so you need to flush it out of your system.
Exactly. And your stools might be white, streaky, or clay-colored for a day or two as the barium passes through. Also, if you need to provide a stool sample for another test, you'll need to wait until the barium is completely out of your system.
And most importantly, if you don't have a bowel movement within a day or two after the test, you need to contact your doctor right away.
That's crucial. Retained barium can potentially lead to a blockage, which can be serious.
So don't hesitate to reach out to your doctor if you have any concerns after a barium test.
Absolutely.
Okay, so that's the upper GI test. What about the small bowel series? How is that different?
Well, the small bowel series is essentially an extension of the upper GI test. It still involves drinking a contrast agent, usually barium, but the focus of the fluoroscopy is specifically on the small intestine. It can take several hours, sometimes up to 6, as they track the barium's movement through the jejunum and ileum.
So they're really getting a detailed look at the small intestine.
They are. This test is particularly helpful for identifying obstructions, tumors, and areas of inflammation in the small intestine.
And if the standard small bowel series doesn't provide enough detail, there's another procedure called enteroclysis, right?
That's right. This is a bit more involved. It involves passing a thin tube, kind of like a feeding tube, down into the small intestine. Then they infuse a thin barium solution, along with a substance called methylcellulose, which is a type of fiber, directly into the small intestine.
And they still use fluoroscopy to watch the barium move through.
Exactly. It allows them to get even more detailed images of the small intestine. This procedure can also take around 6 hours. And because there's a risk of vomiting and aspiration, which is when you inhale fluid into your lungs, the patient is usually positioned on their side, and suction equipment is kept nearby just in case.
Okay, so that's the small intestine. What about the large intestine, the colon? Is there a test for that?
You bet. That's where the barium enema or lower gastrointestinal series comes in.
Tell me more about that.
So for this test, a barium solution is introduced into the colon through an enema. Then they use fluoroscopy to look for polyps, tumors, signs of inflammatory bowel disease, strictures, and other abnormalities of the colon. The radiologist can even watch how the barium moves through the rectum, sigmoid colon, and descending colon in real time.
So it's similar to the upper GI test, but instead of swallowing the barium, it's introduced through the other end.
Exactly. Now, the prep for a barium enema is a bit more intensive than for an upper GI series. It usually involves a thorough cleansing of the bowel with laxatives and sometimes enemas. You might also be on a clear, liquid, or low-residue diet for a day or two before the test.
So no solid food for a while.
That's usually the case, and you'll likely be NPO for about 8 hours before the test. They'll often give you a strong laxative the night before and then more cleansing enemas the morning of the test until what comes out is clear.
So it's quite a process.
It is, but it's important to have a clean colon for the test to be accurate. During the test, you'll probably need to change positions on the X-ray table a few times so they can get good images of all parts of your colon as the barium flows through.
And like with the upper GI test, you'll be given laxatives after the test to help get rid of the barium.
That's right. And your bowel movements will likely be white until all the barium is out of your system.
Okay, so we've covered tests for the upper GI tract, small intestine, and colon. Now, what about the gallbladder? Is there a specific test for that?
There used to be a test called oral cholecystography, or gallbladder series, which was used to look for gallstones, tumors, and assess how well the gallbladder could store a contrast dye containing iodine. It was important to do this test before any barium studies, as the barium could interfere with the images. Patients would take dye tablets, and it's crucial to tell your doctor if you have any iodine allergies, and then they would need to be NPO before the test. After the tests, they'd usually eat a fatty meal to stimulate the gallbladder to contract. But nowadays, ultrasound has pretty much replaced oral cholecystography for gallbladder imaging.
Why is that?
Well, ultrasound is much more convenient, it's faster, and it doesn't use any radiation. It's a really good way to visualize the gallbladder and look for gallstones.
Okay, that makes sense. Now, what about the bile ducts? I know there are procedures specifically for those.
You're talking about cholangiography.
Yes, that's the one. What can you tell me about those procedures?
Well, cholangiography refers to a group of tests that are used to look at the bile ducts, which are the tubes that carry bile from the liver to the gallbladder and small intestine. One important procedure is ERCP, which stands for endoscopic retrograde cholangiopancreatography.
It's a mouthful.
It is. ERCP involves passing a flexible scope down the esophagus, through the stomach, and into the duodenum. Then, using X-ray guidance, a contrast dye is injected into the bile and pancreatic ducts, allowing the doctor to see if there are any blockages, like stones or tumors.
So it's like a combination of endoscopy and X-ray imaging.
Exactly. And a big advantage of ERCP is that if they find stones in the bile duct, they can often remove them during the same procedure.
Wow, so it's both diagnostic and therapeutic.
It is. Now, another technique is intraoperative cholangiography. This one is performed during gallbladder surgery. The contrast dye is injected directly into the bile duct while the surgeon is operating.
So it's done to make sure the bile duct is clear after the gallbladder is removed.
That's one reason. It can also help identify any other issues with the bile duct that might need to be addressed during surgery.
Okay, and I know there's also a type of cholangiography that uses MRI, right?
You're thinking of MRCP, or magnetic resonance cholangiopancreatography. This is a non-invasive way to create detailed images of the bile ducts, the pancreatic duct, and the pancreas itself. And it often doesn't require any contrast dye.
So no needles or scopes involved?
Nope, it's all done with magnets and radio waves. Because it's non-invasive, it's often the first choice for imaging the biliary system.
That sounds a lot more appealing than the other options.
And finally, there's PTC, which stands for percutaneous transhepatic cholangiography. This one is more invasive. It involves using ultrasound to guide a needle through the skin and into the liver to inject contrast dye directly into the bile ducts. Because it's more invasive, there are risks like bleeding and infection.
So it's usually reserved for specific situations where other imaging techniques haven't provided enough information. Okay, we've covered a lot of ground with radiographic studies. What about those non-radiographic tests you mentioned?
All right, let's move on to those. One of the big ones is magnetic resonance imaging, or MRI. Unlike X-rays and CT scans, MRI uses magnets and radio waves to create images. It's really good for visualizing soft tissues, including all the organs in the GI tract. Sometimes they'll give you an oral contrast agent to help see the structures more clearly.
And what kind of prep is involved for an MRI?
Usually, you'll need to be NPO for 6 to 8 hours before the test. Also, it's really important to let your doctor know if you tend to feel claustrophobic in enclosed spaces. They might be able to give you some medication to help you relax during the test. And everyone needs to stay perfectly still during the scan to get clear images.
It sounds like there are some important safety considerations with MRI.
Definitely. Because of the strong magnets involved, they'll ask you a lot of questions beforehand to make sure it's safe for you to have the test. They'll want to know if you have any metal implants in your body, like artificial heart valves, aneurysm clips, a pacemaker, or a defibrillator.
What if you have metal fillings in your teeth?
Usually, those aren't a problem, but it's always best to mention it to your doctor. They'll also ask about any history of kidney disease or if you're on dialysis, because that can affect the type of contrast agent they can use. They'll also ask about things like recent joint replacements, stents, and even if you've worked with sheet metal in the past, because there could be tiny metal fragments in your eyes.
Wow, I never would have thought of that.
And of course, you'll need to remove any metal objects you're wearing, like jewelry, watches, credit cards, hearing aids, even pens and pocket knives. Basically, no metal allowed in the MRI room.
It sounds like they take safety very seriously.
They do, and for good reason. And another crucial thing to mention is pregnancy. If you're pregnant or even think you might be pregnant, you need to tell your doctor before having an MRI.
Okay, good to know. So that's MRI. What about other non-radiographic tests?
Well, there's a specialized type of MRI called magnetic resonance elastography, or MRE. This one combines MRI with sound waves to measure how stiff the liver is. This can be an early indicator of liver damage even before it shows up on other imaging tests. It's less invasive than a liver biopsy and can assess the whole liver, not just a small sample.
So it's a promising tool for diagnosing liver problems.
It is. And then we have ultrasonography, or ultrasound. This one uses high-frequency sound waves to create real-time images of organs. It's great for looking at the size and location of organs, as well as identifying abnormalities like gallstones, pyloric stenosis, which is a narrowing of the opening from the stomach to the small intestine, and appendicitis.
Is there any special prep involved for an ultrasound?
Usually they'll ask you to avoid things that can create extra gas in your system because gas can interfere with the sound waves. This means no drinking through straws, no smoking, and no chewing gum before the test.
So it's a pretty simple test to prepare for.
It is.
Now, what about liver biopsy? That sounds a bit more invasive.
It is more invasive. A liver biopsy is when they took a small sample of liver tissue, usually with a needle inserted through the skin, to look at under a microscope. Because the liver is full of blood vessels, there's a risk of bleeding, so they'll do blood tests beforehand to check how well your blood clots. You'll also likely need to stop taking NSAIDs like ibuprofen or naproxen about a week before the procedure.
In what kinds of conditions can a liver biopsy help diagnose?
Lots of them. It can help diagnose liver cancer, infections like hepatitis, the extent of liver damage from things like alcohol or fatty liver disease, and even signs of rejection in people who've had a liver transplant.
So it's a valuable tool for understanding what's going on in the liver.
It is. During the procedure, you'll need to take a deep breath and hold it while they insert the needle and get the tissue sample. Afterwards, you'll lie on your right side for a couple of hours and then stay in bed for another 8 to 12 hours. It's important to watch for any signs of bleeding, like increasing pain, swelling, or a collection of blood under the skin.
And no heavy lifting for a while afterwards, right?
Right, you'll need to avoid any strenuous activity for about a week.
Okay, we've talked about a lot of different tests. Are there any other important ones we should know about?
There's one more category we should discuss: gastrointestinal endoscopy.
What does that involve?
This involves using a flexible lighted tube called an endoscope to directly look inside the GI tract. It allows doctors to examine the lining of the esophagus, stomach, small intestine, and colon, and take biopsies if needed.
So it's like a tiny camera that goes on a journey through your digestive system.
Pretty much. And there are a few different types of endoscopy. One common one is EGD, which stands for esophagogastroduodenoscopy. As the name suggests, this one looks at the esophagus, stomach, and duodenum.
So the upper part of the GI tract.
Exactly. Before an EGD, you can't eat or drink anything for at least 8 hours. You might be able to take some essential medications with a small sip of water up to 4 hours before the procedure, but no antacids or carafate, because those can interfere with the visualization.
And during the procedure, they numb your throat, right?
Right. They usually spray a local anesthetic into your throat, which can temporarily make it difficult to swallow. That's why they have suction readily available during the procedure.
And what about afterwards? What can you expect?
After the EGD, you'll need to stay NPO until your gag reflex comes back, which usually takes an hour or two. They'll monitor your vital signs, and you'll need to rest in bed until you're fully awake. You might have a bit of a sore throat afterwards, but that usually goes away within a day or two. You can use lozenges, gargle with salt water, or take over-the-counter pain relievers once your gag reflex is back.
And are there any specific symptoms you should watch out for after an EGD?
Yes, definitely. If you experience severe abdominal pain, bloating, a fever over 101, chest pain, difficulty breathing, an irregular heartbeat, vomiting, especially if there's blood in it, rectal bleeding, or difficulty swallowing, you should contact your doctor right away.
Okay, so those are red flags to watch out for.
They are. And another important endoscopic procedure is a colonoscopy.
This one examines the entire colon, right?
It does. It's often recommended as a screening test for colon cancer starting at age 50, or even earlier if you have a family history of the disease.
And the prep for this one is pretty intense, right?
It can be. It usually involves drinking a large volume of a special cleansing solution and taking laxatives. You'll be going to the bathroom a lot until your colon is completely clear.
So it's not the most fun experience, but it's important for early detection of colon cancer.
That's right. During the procedure, they'll give you medication through an IV to help you relax and feel drowsy. They often use a drug called Versed, which can also cause temporary amnesia, so you might not remember much about the procedure afterwards. You'll usually lie on your side or in a knee-chest position during the test.
And what about after the colonoscopy? What should you expect?
Well, you shouldn't drive, operate machinery, drink alcohol, sign legal documents, or do anything strenuous for the rest of the day. You can start with clear liquids and gradually reintroduce food as tolerated. You might feel a bit drowsy or forgetful, and you might have some changes in your bowel habits, gas, or bloating for a day or two. Walking or lying on your left side with your knees bent can help with the gas. If they took any biopsies or removed any polyps during the procedure, you'll need to avoid aspirin and NSAIDs for a week or so to reduce the risk of bleeding. And a little bit of rectal bleeding is normal.
Okay, good to know. And there's also capsule endoscopy. Right, that one sounds pretty high tech.
It is. For this one, you swallow a small capsule that has a camera inside. As it travels through your digestive tract, it takes pictures and transmits them to a recorder you wear on your belt. Later, your doctor can download the images and create a video to see what's going on inside.
Wow, it's like a little explorer going on a mission through your gut.
Exactly.